We'll be talking on role of OCT in neuro-ophthalmology. So the financial disclosure, which is a mandatory slide. The aim of investigation in neuro-ophthalmology is to arrive at a correct diagnosis, assess the damage, predict the outcome possibly, and possibly prevent a systemic catastrophe which is mostly neurological and at times cardiological. OCT is a relatively new advent as a form of imaging in neuro-ophthalmology. The basic principle is that there is a low coherence beam which is split by a 50-50 beam splitter, and the reflected beam from the oscillating mirror and the eye is detected by a photodetector, filtered, processed, and a computer display is seen. There are two forms of OCTs, time domain and spectral domain. Spectral domain or the high definition OCTs have almost replaced the time domain OCT now. Now, what could be the utility of OCT in neuro-ophthalmology? It can be used to assess the optic nerve head abnormalities, evaluation and follow-up of disc edemas, optic neuropathies, and systemic disorders which could involve nerve fiber layer thickness. It allows structural anomalies in the form of anomalies of the disc, loss of nerve fiber layer, or an increase in nerve fiber layer thickness. Anomalies of disc which has been easily seen are optic nerve hyperplasias, Bergmeister's papilla, optic disc pits. Loss of nerve fiber layer is seen sometimes in systemic disorders like Alzheimer's and multiple sclerosis. In all these cases, optic nerve is considered as a part of extension of brain. So whatever is happening in the brain can be seen in the optic nerve also. It is also seen in local causes of neuropathies. It's also seen in neuropathies like toxic optic neuropathy, hereditary optic neuropathy, traumatic and compressive optic neuropathies. Increased nerve fiber layer thickness can be seen in cases of papillitis, papilledema, AIO1, infiltration of the optic nerve, and other local causes like uveitis which can cause a disc edema. Now, what it shows in toxic optic neuropathy? In cases of ethambutol toxicity, there has been reports which show that the more of the nerve fiber layer loss is associated with reduced visual recovery following the toxicity. So this clearly shows that the insult to the optic nerve can show up as a decreased nerve fiber layer thickness. In cases of methanol toxicity, there are two phases. The acute phase shows increase in the peripapillary nerve fiber layer swelling, followed by a chronic phase where there is loss of nerve fiber layer. It has even been tried in cases of pituitary adenoma. It has been shown to predict the visual outcome after the treatment and recovery of visual field defect when we do a pre and post nerve fiber layer thickness. A poor nerve fiber layer thickness points towards a decreased chance of regaining the lost visual field following the treatment for adenoma. Based on this, people tried to detect adenoma with the nerve fiber layer abnormalities, but there was no significant correlation. Any atypical pattern of nerve fiber layer thickness should be evaluated. It may point towards a CNS lesion. In cases of NAION, it has been shown in cases of follow-up. It prognosticate the follow-up of NAION. With every micron loss of nerve fiber layers, there is 2 decibel loss in the visual field defect mean deviation. And with every 1.6 microns loss of nerve fiber layer, there is 1 drop in visual acuity line. This is one of the studies that said. Now, multiple sclerosis, there is demyelination, which is the hallmark of the disease, and axonal and neuronal degeneration. Nerve fiber layer is very unique. It has got axons and glia, but no myelin. So it's ideal structure to visualize neurodegeneration, neuroprotection, and if there is a possibility of neuro restoration by therapy, it can also be seen. In case of MS, the OCT shows loss of nerve fiber layer thickness and loss of macular volumes, and this points towards disorganization of the optic nerve head structures even in the absence of optic neuritis, and making the anti-visual pathway as an ideal mode of imaging in these cases. It helps us in classifying the MS in the form of relapsing remitting, secondary progressive, primary progressive, or progressive relapsing forms of MS. Nerve fiber layer thickness and macular volumes were significantly reduced in secondary progressive as compared to a primary progressive form of multiple sclerosis. Axonal loss is indicating towards progression of multiple sclerosis. If the serial OCT scans are showing that there is a serial loss of nerve fiber layer, probably the MS is progressing. So this shows that it can be a clinically silent form of demyelinating process, and there can be gradual nerve fiber layer loss which can be revealed by an OCT. Nerve fiber layer defects do correlate with the perimetry in cases of multiple sclerosis. There is very high chance that it correlates maybe up to an 86% of cases. And in these cases, there is no any episode of previous optic neuritis. So serial MRIs can they are usually utilized to assess the progression of MS. Serial OCTs can also help us probably monitor the disease, predict the disability, and also help us in finding out the effect of neuroprotective therapies. So in multiple sclerosis, there can be various utilities of OCTs like mechanism of MS study, neurodegeneration and neuroprotection. Various subtypes of MS can be classified based upon the OCT findings, assess and predict visual field defects. Future risk of MS and brain atrophy can also be assessed if there is serial loss of nerve fiber layer and association of physical and cognitive disability with the nerve fiber layer thickness. Now we move on to a few cases. This is a case of right eye poor vision since childhood. The fundus picture shows there is a small optic nerve head which points towards an optic nerve head hypoplasia. But when we do an OCT, we find out there's a Bergmester's papilla over the optic disc pointing towards the cause of the poor vision. So it's a developmental anomaly that there's, along with the optic nerve head hypoplasia, there is a Bergmester's papilla. Another case where we can see optic disc pit. So we do an OCT scan, we find out that there is a schisis cavity and there is a connection of the serous detachment with that of optic disc pit. So this is a case of optic disc pit with serous macular detachment. Another case, again we have an optic disc pit here, and there is something, the fundus picture looks like that there is another case of serous detachment of macula which is communicating with the optic disc pit. But once we do an OCT, we find out that there is some spongiform edema of the retina, but there is no connection here. It can also be utilized to follow the disc edema cases. This is a case of 17-year-old female who had a history of headache, no other complaints. Fundus showed mild nasal blurring of disc margins with swelling. So this was a case of early disc edema. So we performed an FFA. We can see there is a nasal leak. Detailed neurological evaluation was unremarkable. CECT was normal. So she was diagnosed as IIH or BIH. Now we put the patient on acetazolamide, and these are the serial scans. We can see there is a decrease in the elevation of the nerve fiber layer thickness of both eyes, and after this there is no further decrease. So we are again subject her to an FFA, and now we can see there is hardly any leak. So this is a time to stop maybe acetazolamide for her. A case of pituitary adenoma. This is a case of 19-year-old girl who had a pituitary adenoma, and she's already on treatment with kebagoline for last 5 years. And this is the fundus picture, which is showing bitemporal disc pallor. A detailed ophthalmological evaluation was done at the time of diagnosis. Fundus was normal reported, and fields were reported normal with a normal visual acuity. At present, she has an MRI where there is no edema, and this is the fields today. There is no field defect. So this is the pre-treatment MRI CT scan where we can see a pituitary adenoma, and this is the OCT picture of the patient. We can clearly see the superior pole and the inferior pole are showing decreased nerve fiber layer thickness, and this is the macular program which is centered over the disc to show you the elevation and depression of the optic nerve head. So this indicates probably there is a optic nerve fiber a nerve fiber layer loss even with the absence of field defect. So there were some flaws in the management, like there was no MRI which was performed at the time of diagnosis. The treatment was started on the basis of CT scan, and CECT could not actually assess damage to the chiasma because it's not good for soft tissue assessment. Now we move on to a case of ischemic optic neuropathy, a 70-year-old male with a history of sudden diminution of vision in the right eye for last 7 days. Lost the left eye about 5 years back. He's a hypertensive with antihypertensive treatment for last 15 years. ESR and CRP has been done because of his age, which is normal. Now, following detailed ophthalmic evaluation, he's been diagnosed as NAION in the right eye and optic atrophy in the left eye, which is post-AION. So we just do a OCT scan for an academic interest. OCT reveals that there is an increased nerve fiber layer thickness in the right eye and decreased nerve fiber layer thickness in the left eye. And this is again the macular program which is centered over the disc to show you the elevation and depression. So we can clearly see there's an elevation of the nerve fiber layer thickness here and depression here. The similar things are depicted here and here. So to conclude, OCT as a tool may have multiple useful applications in neuro-ophthalmology, but a careful evaluation in the form of pupillary assessment, visual function assessment, neurological evaluation, and detailed 90-day evaluation of the optic nerve head is a must. Thank you.